errors in imaging, very, very important, interfering food and medication. We have a withdrawal checklist, and it's very, very strict. It's only slightly less strict than the pre-PET diet. Anyone who undergoes a PET scan, we have them undergo a strict South Beach diet for 2 days before their PET scan. Well, for thyroid therapy or for thyroid uptake and scanning, we have a diet that excludes milk, salt, and the worst offender, chocolate. People are horrified when they've got to be off chocolate for 10 days. The thyroid problem not bothering them at all. Chocolate? Recurrent telephone calls. So anyway, remember, interfering foods and medications can interfere with your results as well as your treatment. Thyroid nodules, if palpable and if you have a high risk factor, are easily studied using fine needle aspiration. However, you can have false positive as well as false negative rates. There is not a significant risk if you've done these carefully, and we usually use a coaxial system and ultrasound guidance. When are you increased in your suspicion level? If you're very young, you're very old, and remember, men. If you have men who are much older and have had radiation exposure, more likely to have thyroid cancer in their nodules. And this is a simple flow chart. If it's more than 1 centimeter in size and you are suspicious, you're going to do a fine needle aspiration. The smaller they are, with no regional lymph nodes, just follow them up clinically. There's no need to do additional aggressive imaging. If you find incidental papillary carcinoma during neck dissection for other head and neck cancers, they're going to be followed up by the iodine-131 scan and the ablative dose. So that's a fairly easy way of looking at the thyroid nodule. What about follow-up for thyroid nodules? If you have follicular cancer, you're going to check the TSH level. If you have other types of epithelial or medullary cancers, you're going to follow them up with other scans. For example, medullary cancers are going to be neuroendocrinologically active. So not going to use an iodine-131 scan. You're going to use another type of scan, which we'll talk about. The iodine-123 scan, if it is hot and you're thyrotoxic, only then are you going to give iodine-131. You need clinical as well as chemical evidence, in addition to scintigraphic evidence, before you can treat somebody with iodine-131. On the other hand, if you have cancers, the histology of the cancer determines how you're going to follow these patients. For example, if you have a medullary carcinoma and you're going to follow them up, you're not going to use iodine-131. You're going to use a pheochromocytoma screen, for example, an octreotide study, because that's a neuroendocrine histology, and that's what you're going to follow up. A papillary or follicular cancer, you're going to follow with a whole body radioiodine screen. In recent times, we've had approval for thyroid cancer, but not very open. The restrictions are tremendous. You can follow thyroid cancer only of follicular histology. These were studies lent to me from Sloan Kettering Medical Center. If you compare FDG PET scans to thyroid scans, these are iodine-131 scans. We don't see much activity in the lymph nodes, but on the FDG PET scan, we see activity not only in local lymph nodes, in the hilus and mediastinum, but we also see lung parenchymal activity. Now, since October of last year, I think it's October 4th or 5th, we are able to do FDG PET scans, and we can get reimbursed for this. You'll have to check the G code in your syllabus, only for follicular histology, only if the iodine-131 scan is negative, and you have a rising serum thyroglobulin level. So it's like a lunar eclipse. If everything happens and you're still suspecting metastatic thyroid cancer, can you do an FDG PET scan? The reason is more newer agents are going to be made available to look at thyroid cancer, and we're probably going to go to a more specific agent rather than FDG. One of them that has been postulated is iodine-124 PET, and as you can see, it's much more sensitive and much more specific. This is the same patient. On FDG PET, you don't see anything, obviously didn't see anything on iodine-131 either, but by using iodine-124 PET, you're picking up more lesions. So the reason is probably going to be for follicular, you're restricting yourself to FDG. For papillary, you're going to use an iodine PET scan. So we're going to get more specific, and that's the role of PET CT in the future. We're going to talk about that tomorrow when we talk about PET scanning. So a summary for the restaging of thyroid cancer. I know I have thyroid cancer. I have an elevated thyroglobulin. I know my histology. That's very important before I decide what follow-up study I need. If it's non-medullary, I'm going to get an iodine 131 scan. If this is positive, depending on the degree of positivity, is it in the thyroid bed, local regional lymph nodes, or distant metastases, I'm going to get higher doses, not exceeding 300 millicuries in one setting, not exceeding 1 entire curie my entire lifetime. If it is negative, but I still have an elevated thyroglobulin, only if it is follicular am I approved for an FDG PET scan. If I have a medullary histology, I'm going to start off with an octreotide scan, indium 111. If this is positive, then I know where the disease is, surgical therapy. If this is negative, I'm going to do an FDG PET scan, but at the current time, it is not approved. So this is the basic flowchart for restaging of thyroid cancer. A brief note on parathyroid imaging. Parathyroid imaging was incidentally discovered because of cardiac imaging. Myocardial perfusion uses technetium 99M sestamibi, and we discovered that on delayed imaging, we often saw uptake in parathyroid as well as thyroid adenomata. This is very important. It is not only a hyper-functioning parathyroid adenoma that uptakes and doesn't wash out too quickly, the MIB that is fed to it, it is also thyroid adenomas. So only in the setting of elevated idiopathic hypercalcemia are you going to suspect the existence of a hyper-functioning parathyroid adenoma. Please remember, it's sensitive, but it's not specific. The other way of doing it, the older way, was the dual isotope subtraction technique. Very painful. You don't have to move. You've got to stay absolutely still. You've got to have no misregistration artifacts. Very, very challenging. Plus, there are 2 doses. Whereas the MIB study is extremely simple because you're only looking at washout. If it doesn't wash out, you know it's an adenoma. If you've got an adenoma and idiopathic hypercalcemia, you know that that is where the hyperfunctioning parathyroid is. The dose is 20 millicuries. Initial images are obtained at 20 minutes. Late images at 2 hours. We almost never need to obtain delayed images that are ultra delayed for 4 to 6 hours. That's optional. I've never really needed it because a really hyper-functioning adenoma is going to show very intense uptake. The additional image is not going to change your differential diagnosis. So don't waste your time and camera time by doing these additional images. The importance of the washout study, why are we doing this? It shortens intraoperative time and it reduces the cost in virgin cases. It shortens intraoperative time considerably in repeat cases when you have to undergo exploration in people who've already had their parathyroid glands removed. It is significant in reducing intraoperative time. Any combination of ultrasound, CT, or MR with MIBI scans is going to increase your specificity and sensitivity tremendously. So using just any one modality is going to be fairly good. If you combine it with isotopic studies, you're going to be better off. Why do you have to do this combination thing? Because of the false positive from thyroid adenomas, and if you have very small lesions which are not physiologically active. Now remember, if they're not physiologically active today, they may recur in 3 to 4 years from now. So that's the reason we use dual imaging. Also, if they're very small adenomas, the smaller the adenoma, the less likely you are going to be able to find it. We always use a combination of in vivo and in vitro imaging. So we always do the functional imaging in the nuclear medicine area, and then we have the intraoperative gamma probe. We use the same intraoperative probe that we use for sentinel node mapping for melanoma and breast cancer, but we use a combination of this. Using film as well as your intraoperative probing increases your specificity and your uptake value significantly. So if you do this combination, you have greater than 90% sensitivity before surgery. Remember, if the parathyroid adenoma is big enough that you can see it on MRI, if you can see it on MRI, they can feel it in the tracheoesophageal groove. This is not challenging. My mother could find this. It's the smaller ones that are really tiny but hyper-functioning. And remember, there are 4 parathyroid glands. So you may have as many as 4 foci. One of them could be ectopic in the thorax. And that's the retrosternal one that you can't feel and that you have missed because your field of view has not gone that far. For that reason alone, you're using nuclear medicine. When you combine that with intraoperative probing, you're finding small levels of radioactivity, and it's tremendously helpful. It reduces intraoperative time, especially in the elderly, where we do prefer it even if you haven't had surgery before. If you're a high-risk candidate for surgery, we don't want you to undergo multiple episodes of surgery, so we do it the first time. It reduces the extent of dissection. Remember, bilateral neck dissection takes twice as long as unilateral neck excision. And again, the risks of surgery and anesthesia itself. Again, I urge you, if you're doing only intranuclear medicine imaging, please add on the intraoperative gamma probe. It doesn't add time or anything. You don't have to redose these people. You just have to time it according to surgery. So you want to time it so you're injecting them approximately 2 hours before they go into the operating theater. So you've got all your cats in a row. The intraoperative gamma probe, again, surgical approach. Where are you going to go? How are you going to track it using your probe in the OR itself? SPECT can be useful if it's very, very deep in the mediastinum. You can use it. Usually, again, when you see a good-sized adenoma, it's going to really light up. And it's not going to make too much of a difference, but it may help in anatomic localization if you're doing SPECT with CT fusion. Again, very rare, but if you have the intraoperative probe, you don't really need that as well. If you combine lesions and if you sample with invasive studies, the combination is going to increase your sensitivity. So that's another option that you may think of. Reoperation for a missed adenoma. These could be anywhere. They could be within the thymus. They could be within the thyroid. You're not thinking hard enough about the embryology of these parathyroid glands, and that's why you're missing them. They could have never descended. They could still be in the skull base. They could be in the carotid sheath. We've even had some cases related to the esophagus. If you do a MEB scan, it's a non-anatomic structure. It's a non-anatomic study. So anything that lights up is going to be where the adenoma is. So it's really a tremendously useful study. You hardly get any false positives. With the other studies, you do get a few, and that could be a little bit of a problem. Use multiple techniques if you're not confident using MEB itself. The more you combine, the more your true positive rate is going to go up. Remember, the more you combine, your sensitivity is going to fall as well. So it's a little toss-up. In my experience, a combination of just 20 minutes and 2 hours of MEB and intraoperative gamma probing is the best deal out there. Errors in parathyroid imaging, the most important one is the ectopic adenoma. So use a larger field of view. People try and restrict and use a pinhole camera. Do not do that because you could be anywhere between the skull base and the infrabronchial segment of the esophagus. And don't forget withdrawal criteria. You've got to have recent withdrawal of some dietary things that could interfere. So in summary, for thyroid space imaging, sonography to guide biopsy, it does not define the presence or absence of cancer. For diagnosis and treatment of hyperfunctioning and cancer, you've got to use nuclear medicine techniques. FDG PET is not universal, only applicable for follicular cancer with higher serum thyroglobulin levels, more than 10 milligrams per cc, and you've got to have a negative iodine 131 scan. Non-FDG PET, maybe same time next year, we'll be talking more about that. And parathyroid study, it is needed in high surgical risk patients for their first-time surgery. In patients who've had repeat surgery where they have persistent elevations of calcium, life-threatening adenomas, if the calcium really needs to be controlled immediately, persistent, recurrent, or ectopic thyroid adenomas. Temporal bone is a scary structure because it's a complex structure, it's a complex pyramid, and it's got several segments. What better way to look at it than to analyze the various segments? Each segment has definitive anatomy, pathology, and embryology, and if you know that, it's pretty easy to figure out what is going on within the temporal lobe. The first thing to remember is that the temporal lobe has 5 segments. The squamous segment, the mastoid segment, the Petrous segment, the tympanic segment, and the styloid segment. This is important to realize because pathology can involve any of these segments, and specific pathology affects specific segments. You can analyze the temporal bone using either CT, which is typically done when you have any form of conductive hearing loss, and MR when you have major hearing loss, which is a combination of conductive with sensory, neural, or sensory neural or mixed hearing loss. You also use MR to look at the central pathways. Temporal bone CT is typically done with a biphasic acquisition. You want to acquire source images in the axial supine as well as the coronal planes. The coronal images are typically achieved in a prone fashion if the patient can cooperate with this plane of acquisition. Section should be quite thin. 1 millimeter is thin enough. You can get thinner sections, but then you see too many foramina and you have no idea what's going on. So 1 millimeter is a pretty standard way of acquiring images. Again, supine and prone images, so you want to get two acquisitions, and you do not want to try and attempt reformations because a few of the structures are very tiny and cannot be adequately visualized. Inner ear MRI is typically acquired in the supine position. You may or may not want to give contrast. Typically, contrast is administered if you're suspecting neoplastic or vascular pathology. But most of inner ear MRI does not require any contrast. Remember, your inner ear functions may be affected by anything along the brain itself. So you want to analyze the whole brain in at least one sequence. Probably the quick and dirtiest sequence to do this in is a whole brain T2 FSE quick sequence. You want to know beforehand whether or not the patient has sensory neural hearing loss and or vertigo. Depending on these combinations, you want to get additional imaging of the brain itself that is outside of the temporal area. If you have tinnitus, which is a continuous ringing in the ears, it may be worth your while to get high-resolution 3D time of flight T2 star MR angiography, because vascular loops, vascular anomalies, and vascular neoplasms can cause this kind of a problem. So let's look at the temporal bone. Now, this is very simple anatomy if you break it down. So work with me over here, and we're going to look at the left temporal bone on all these images, just so we're consistent in dealing with the anatomy over here. This is the temporal bone on the left side. This is anteromedial. This is anterolateral. This is lateral, and this is posterior. So what you have is demarcations by the pinna laterally, by the anterior cerebellopontine sulcus anteromedially, by the posterior cranial fossa medially, and the middle cranial fossa anterolaterally. So these are the margins of the temporal bone itself. Now we're going to split up the temporal bone into its various segments. The squamous segment has to be included in your field of view. Why do I state this? Because the squamous segment extends anteriorly and anterolaterally. It's a flat bone. Squama means flat. And oftentimes you may exclude this in a field of view because you want to get a crisper image. You may miss pathology in the squamous part of the temporal bone, mainly because it has been excluded from the field of view. The squamous segment extends anterolaterally and is in front of the pinna. Remember, the pinna is our lateral landmark. Being a flat bone, it can be affected by any of the pathology that affects flat bones. Typically, you see post-traumatic changes in this location involving any combination of the zygomatic body, the zygomatic process, or the zygomatico-squamous articulation. The temporal bone is flat. Sometimes, however, it may be partially pneumatized. Remember, if any segment of the temporal bone or any bone is pneumatized, it does lead to secretions, and you can get secondary infections, effusions, and empyema in that location. So again, common things. This is a good location for trauma. This is a good location for subtle underlying epidural hemorrhages, which may be completely masked. As such, it forms the lateral wall of the middle cranial fossa. So if you have arachnoid cysts in this location, there may be thinning of the inner table. If you have meningiomas in this location, you may get a low-grade, non-erosive osteoblastic response from the underlying squamous temporal segment. As you follow the squamous segment posteriorly, you approach the glenoid fossa within which lies the mandibular condyle. This is a very important location because occult fractures through either the glenoid fossa, the articular eminence, or the mandibular condyle may be excluded from your field of view if you concentrate only on the mastoid and the petrous segments. So again, it's very critical to include the entire temporal bone in your field of view. Going on to the mastoid segment of the temporal bone, this is a segment that is typically aerated, but not at birth. It aerates over time. As one grows older, you see more and more aeration, and aeration of the mastoid segment is variable. Typically, you have air cells that extends far behind into the perisigmoid region. Air cells may extend anteriorly and may pneumatize the petrous segment of the temporal bone as well. And as we just saw, some of the air cells may extend anteriorly into the squamous segment. So you can get partial or asymmetric pneumatization. However, if you see pneumatic cells, they all have to be well aerated. The more air cells you have, the more likely you are to get a mastoid effusion. Remember, do not call it mastoiditis. Mastoid inflammation is a clinical diagnosis. Mastoid effusion is what we see, which is opacification of the mastoid air cells. Typically, if you have bilaterally opacified mastoid air cells, it's more likely going to be post-obstructive pathology at the openings of the eustachian tubes related to the fossa of Rosenmuller in the retropharyngeal space. On your MRI, remember the mastoid air cells extend from the mastoid process, which is the origin of the sternocleidomastoid muscle. Related to that are the digastric muscles. The digastric muscles in cross-section may often be mistaken for pathologic lymphadenopathy. Please be aware of this muscle in this location so you do not overcall pathology related to the mastoid air cells. Anteriorly is the squamous segment of the temporal bone. Posteriorly is a very thin plate which divides the mastoid air cells from the sigmoid sinus. This plate is called the sigmoid sinus plate and sometimes may be very thin or dehiscent. This is important because if it is thin and or dehiscent, inflammation or infection within the mastoid air cells may progress into the sigmoid venous sinus, causing sigmoid sinus thrombophlebitis and very rarely sigmoid sinus thrombosis. The roof in this location can also be very thin. The roof is called the tegmen or the roof of these air cells. If this is thin, infection in this location can enter the middle cranial fossa, it can enter the epidural space, and you can get epidural inflammation, but more rarely epidural empyema. So look at these normal anatomic structures, because if you've got effusion and an anatomic variant which is thinning or a dehiscent plate, you have a pre-setup for spread of infection. There again, very, very thin tegmen, very thin roof of these air cells. Any inflammatory or neoplastic process can very easily spread superiorly. These air cells communicate through the epitympanic recess with this segment, which is the tympanic segment of the temporal bone. Tympanic, so called because it has to do with the process of accumulating, gathering, and amplifying sound waves from the external atmosphere. The most critical part of the temporal bone is going to be the petrous temporal bone. It's petrous because it is the hardest bone in the body. It is like rock. It is shaped like a pyramid, so we often call it a Petrous pyramid. It is demarcated medially by the anterior cerebellopontine sulcus and laterally by the middle cranial fossa, and it contains various vital structures. So it's very important to realize the complex anatomy of the Petrous pyramid, and this is the Petrous pyramid extending all the way to the apex of the temporal bone. The Petrous pyramid contains two critical structures, arterial and venous. More medial and anterior are the carotid system, more lateral and posterior are the jugular system. You have these critical structures traveling through the Petrous bone, and this is why the Petrous segment is the hardest bone in the body. You do not want to break it unless you're really undergoing significant axial or radial loading injury. As a pyramid, it has complex surfaces, apices, and bases. Again, this is very, very complex to realize this in 3D, but remember this, the anterior surface abuts the middle cranial fossa. So pathology that either erodes or effaces this necessarily arises from the middle cranial fossa. Neoplasms in the middle cranial fossa are going to have an effasive response upon the anterior surface. Posteriorly, anything arising from the infratentorial compartment in the posterior fossa are going to affect the posterior surface. Intrinsically, you have these blood vessels within. They're typically within the carotid canal or the jugular canal. These canals are bony canals, but their osseous walls, again, like the tegment tympani, may be thin or dehiscent. That is a problem again, because here you have apparent herniation of a segment of the intrapetrous segment of the internal carotid artery within the ear itself. If you have any inflammatory condition, it can easily affect the blood vessels and you can get a systemic response. So this is a variation of normal, incidentally noted, but it's important to note this in cases of patients going in for surgery, because this is a trap that people need to be aware of before they open up the ear. Looking at the Petrous pyramid, and this is the pyramid that more people are familiar with. We've got anterior, posterior, inferior, and apical surfaces. This is the osseous edifice. This is the disadvantage of CT. You can infer as to what is going on within the Petrous pyramid by the structures around the vital structures, the osseous edifice that supports them. You do not per se see all the nervous and the vascular structures within the Petrous pyramid. To do that, you have to get MRI. The inner acoustic pore is a classic landmark which is reliably and reproducibly seen on CT examination. This is the connection of the auditory apparatus internally to the central brain auditory apparatus. Any pathology in this location is going to cause severe interruption of the auditory pathways. This is where the inner ear canal, which is right over here, is going to join the subarachnoid space. All of these structures connect in one way or the other to the inner ear canal, which exits over here at the inner acoustic pore. What we see over here, shaped like a snail shell around a modiolus, is the cochlear. You do not see the cochlear itself on CT. All you are seeing is the housing for the cochlear. Again, you're inferring it by interpretation only. You do not actually see the cochlear using CT. Similarly, you can see the 4 nerves within the inner ear canal using MRI. But if the inner ear canal is very, very small, then you know that there is hypoplasia of 1 or more nerves. Which of these nerves is hypoplastic cannot be determined by CT, but it can be determined by MRI, because these 4 nerves, the superior and inferior vestibular nerves, the facial nerve and the cochlear nerve, have a reliable location within the inner ear canal that is reproducible on MRI. You want to compare the relative volumes of these nerves in cross-section in order to determine if any of these nerves are hypoplastic or whether they're pathologically enlarged, which typically means they have within them a neuronoma or a schwannoma. Pathological enhancement of 1 or more of these nerves can be associated with autoimmune or other inflammatory processes. Again, you're not going to see these nerves on CT, you're going to get an inference. You're going to see these nerves directly on MRI, and therefore CT and MRI are complementary when assessing the inner ear canal and its structures. In addition, there are 2 other aqueducts. One is directed posterolaterally. It's directed towards the venous structures, towards the sigmoid sinus, and it is perpendicular to the inner ear canal. V for venous structure, V for vestibular aqueduct. You may or may not see it. If you see it too easily, it means it is pathologically enlarged, and that is called the enlarged vestibular aqueduct syndrome. If you can see it from across the reading room, that child is going to have some degree of sensorineural deafness as well as equilibrium problems. The cochlear aqueduct, however, is invariably seen, and it's seen quite easily. As compared to this aqueduct, which is tinier, this is larger, and this is parallel to the inner ear canal. So it's vertically below and parallel to the inner ear canal. You must always be able to see the cochlear aqueduct without any difficulty. The vestibular aqueduct is subdural in location and directed posterolaterally. The vestibular aqueduct may or may not be invariably seen. The cochlear aqueduct must be seen consistently. It is parallel to the inner ear canal, and this in fact is subarachnoid. Why is this important? If you have meningitis, you can get spread of infection or inflammation along the cochlear aqueduct, and you can get spread of disease into the central labyrinth, and that is a bad thing. You can have hearing loss because of this. In children who are pre-surgically studied for possible cochlear implantation, you want to comment on the medial flare of the cochlear aqueduct. You have to be able to see the cochlear aqueduct. You have to be able to see it flaring slightly medially before cochlear implantation is to be considered. That's an absolute must. And the clue is it is parallel in axis compared to the inner ear canal. The carotid canal is more anterior, the jugular foramen is more posterior. Remember, the carotid canal has horizontal and vertical segments. The jugular foramen may or may not be separated from the carotid canal by the carotido-jugular septum. That is just a variation of normal. However, if this septum is not present, you do have an increased incidence of tinnitus. You hear vascular ringing because of neighboring flow patterns and conduction waves from this location. That is again a variation of normal. And you can see the trigeminal nerve in the general location, but it does not belong within the Petrous bone itself. Inflammation at the Petrous apex may spread in neighboring regions and may affect other nerves which have to do with that location. The central skull base, it's very important to analyze the central skull base not only in the axial plane, but the coronal plane as well. This is because the Petrous carotid segment has both horizontal and vertical portions. So you want to analyze the entire course of the carotid system within the Petrous segment of the temporal bone. The tympanic segment has to do with the auditory apparatus. The tympanic segment is what we easily recognize as the center or the bulk of the temporal bone. It is bounded laterally by the pinna and medially by the Petrous pyramid. Within the tympanic bone itself, we first approach the outer ear canal. Remember, the inner ear canal connects the Petrous pyramid with the subarachnoid space. The outer ear canal connects the Petrous pyramid with the external atmosphere. It is an organ that receives, localizes, and then internally amplifies sound for the central auditory pathway. The outer ear canal has a cutaneous component, a cartilaginous component, and an osseous component. Why is this anatomy important? At these transitions of epithelium, you are more likely to get dysplastic epithelium and therefore squamous cell carcinoma. Similarly, depending on what segment of the outer ear canal is involved, if it's cutaneous, any skin problem can arise in that location. If it's osseous, any osseous tumor, like an osteoma, can arise in that location. Similarly, if it's cartilaginous, you can get cartilaginous problems. So the anatomy is important because the epithelium determines the kind of pathology that's going to involve that segment of the outer ear canal. The segments of the pinna can be easily seen on MRI, the helix, the antihelix, the tragus. They are better visualized by direct inspection of the ear. Oftentimes you're going to miss melanoma or squamous or basal cell carcinomas of the helix and antihelix simply because these areas are squished in place by the head holder of your CT or MRI. So if you miss a subtle finding in the pinna, do not really take it too hard, because remember, these are easily diagnosed clinically. You're doing the study not to look at surface pathology, but to look at internal extension to determine the extent of surgery after diagnosis. Again, we have the osseous segments, we have the inner lining. This is easily seen on axial as well as coronal imaging. Pathology in the pinna may be eclipsed depending on the head holder. We try not to use any earmuffs or head holders when we're doing MRI, but we're still going to miss subtle lesions which on clinical inspection are pretty obvious and pretty gross histologically. As we enter the middle ear cleft, which is this area that is separated from the outer ear by the tympanic membrane, we should not see any concrete division. Remember, if you see a tympanic membrane, it is pathological. A visible, to the naked eye, a visible tympanic membrane indicates that it has undergone retraction fibrosis because of one or more episodes of inflammatory change. The normal isovascular tympanic membrane is not visible on CT or on MRI. So we don't know exactly where it is, but that's the approximate location. If you do see the tympanic membrane, as you barely do in this case, you know that there has been at least one episode of inflammation, and hence there has been retraction fibrosis in that location. Don't forget the styloid process. It's a very small process. Just like the mastoid air cells, it develops after birth. So you do not see the styloid process in children under the age of 4. It's important because it serves as the point of attachment for the stylohyoid ligament, which may be calcified and lead to dysphagia. But more importantly, it helps you divide the parapharyngeal space into the pre-styloid and the post-styloid space. As we discussed yesterday, you should have nothing in the pre-styloid parapharyngeal space except fat. In the post-styloid space, you have 90% of adult pathology, which is related to vascular structures in that location, anteriorly the carotid system, posterolaterally the jugular venous system. Related to the styloid process is the stylomastoid canal, which you can see as a canal within which the facial nerve runs. Unless you have 1 millimeter thin sections and you're reviewing this off the monitor, it may be quite difficult to appreciate the entire course of the stylomastoid canal. You may just see the stylomastoid foramen at its origin. If it is thinned out, if it is eroded, if it is enlarged, then you must suspect facial neurinomas or facial schwannomas in that location. It is the course of the facial nerve once it passes out of the head. The segments of the ear are then divided with respect to the tympanic membrane on the coronal plane. When you enter the middle ear cleft, anything in the plane of the tympanic membrane is called the mesotympanum. It is the central cavity of the middle ear cleft. Anything above it is above the tympanic membrane or epitympanic recess or attic. Anything in the base, anything inferior to the level of the attachment of the inferior limbus of the tympanic membrane is in the basement or the hypotympanum. Remember, bad things lurk in the attic, things we should all be getting rid of, but things we don't know actually lie there. Nothing should be in the basement. There are no vital structures in the hypotympanum. All of the vital structures are housed within the house of the middle ear cleft, which is the mesotympanum. And the attic is something that you cannot see by direct inspection, even through the perforated eardrum, unless you've got windy, angled instruments to evaluate that. So the reason we're doing temporal bone CT or MR in people who have cholesteatomas or middle ear effusions is not to differentiate one from the other. It is impossible to do that unless there are complications. You're doing it to assess extension of this process into the attic or into the basement, because these areas are not ordinarily visible to the ENT surgeon, and you want to help her by giving her that kind of information. The epitympanum arises above the scutum, which is just an eccentric projection of the temporal bone. And in there you have portions of the middle ear ossicles. So you do have some vital structures, and therefore if you have epitympanic pathology like effusions in the middle ear region, you are going to get some degree of conductive hearing loss. But remember, nothing in the attic. So if you have early disease in the basement, in the hypotympanum, these patients are still going to be asymptomatic. In the mesotympanum, you have most of the middle ear ossicles, and you also have a complex system of ossicular ligaments. The ligaments are not ordinarily visible using 1 millimeter thin sections. If you want to analyze for ligamentous morphology, for ossicular replacement, or for ossicular fractures, we typically get sub-millimeter sections and reconstruct them in 3 dimensions. Again, that's very specialized surgery. The ossicles from outside to in, again, this is the tympanic membrane. We're looking at the left temporal bone, that's lateral. This is medial. We start out with the malleus, which looks like a hammer. We've got the incus, which looks like an anvil. We've got the stirrup or stapes. The footplate of the stapes is connected to the oval window. Sound is collected by the drum-like tympanic membrane. It is cleaned up and transmitted through the body of the incus into the superstructure, the footplate, via the anterior and posterior crooks of the stapes, transmitted to the oval window. Sound is then amplified into the inner auditory pathway. It's a very complex system, but it has a method to its madness, and it's a requisite in order that you do not have conductive hearing loss. Again, you can always see the ossicles, but you may not always be able to see the ligaments that support these ossicles. The stapedius muscle and stapedius tendon may or may not be fortuitously seen if you have 1 millimeter thick sections. However, if you ever suspect incudostapedial subluxation or dislocation, you must get thinner sections in order to define the inner muscular and ligamentous anatomy better. The hypotympanum, as we alluded to earlier, has no vital structures, and therefore disorders in this location may go undiagnosed and asymptomatic for a very long time. As we approach the inner ear, we have the membranous labyrinth, which is within the ossific edifice, whether it is the semicircular canals or the cochlear, and you have the osseous structures around them which are susceptible to osseous pathology. For example, you could have osteopetrosis in this location. You could get metastases. Most importantly, you could get complex fractures that may or may not be associated with hearing or balance disorders. Within the vestibule, you have the utricle and the saccule, as well as the semicircular canals. The membranous labyrinth is better evaluated using MRI because you cannot really see them on a CT examination. The vestibular and cochlear aqueducts are part of the osseous labyrinth. Within the cochlea itself, you have slightly more than 2 turns. It's between 2 1/4 and 2 3/4 turns. As long as you see a basal turn, a complete basal turn, a complete intermediate turn, and this is not really a turn, it's just a cupula or a little cap at the head of the cochlea, you're fine. Anything else is called a cochlear deformity. In the olden days, these were described as Mondini and Michel deformities, but there's such a huge spectrum. If you see any other anatomy that is variant from the basal turn, the intermediate turn, and the cupular apex, you call that a cochlear deformity because this is invariably associated with some degree of hearing loss. You're not going to see the scala, the tympani and vestibular and media using either CT or MR unless you do high-resolution MRI, but you can actually see the turns within the bone itself, and that's very critical to evaluate. You see the basal turn, you see the intermediate spiral, and you see a bit of the cupula or the apex. At the center, winding around these turns, in the center is an osseous structure called the modulus, which houses key anatomic structures that transmit neurogenic currents into the center of the brain. Again, basal turn, intermediate turn, and a little blob at the very top, which is not a complete turn. If you want to visualize the scala themselves, you have to go on to MR. And remember, this is a simple MRCP technique. It's MR hydrography. Very, very quick technique. You're using long TR weighting and reforming using maximum intensity projection. Use rotational images so you can see these turns. The defect that you see has no fluid because that is bone, and that is a central modulus around which the cochlea swirls. At the same time, you're seeing the semicircular canals. It's so much easier to see the semicircular canals on MRI when compared with multiple CT evaluations. The nerves within the inner ear canal arise from the cochlear and the vestibular labyrinth. So obviously the one arising from the modilus is going to be the cochlear nerve. The one arising from the vestibule is going to be the vestibular nerve. Depending on whether it's superior or inferior in location, it will be the superior or the inferior vestibular nerve. The beauty of these structures is that they are reproducible and reliably seen every time you do MRI. So if you don't see the cochlear nerve, you know that it is significantly hypoplastic. This child is not a candidate for cochlear implantation. If you see a nerve with focal enlargement, then you know that herein lies some kind of nerve sheath complex tumor. It could be a neuroma, a neurinoma, or a schwannoma. It's impossible to tell one from the other. But the surgeon needs information on the size, the volume of the tumor, and its extent in order to determine the approach to surgery. So you don't really need contrast if you get thin section images and are able to reliably visualize the nerves within the inner ear canal itself from their origins in the vestibule or the cochlea. Cochlear implant, this is a recurrent question that comes up in the clinic all the time. The younger the patient, the better the prognosis. The sooner you implant an artificial cochlea, the better it is. Remember, you have to screen in older kids because these kids have a poorer prognosis. So the younger you are, more under the age of 5, with normal visible cochlear nerves, with no sequelae of meningitis. You don't have sealing off of the cochlear aqueduct, the better the prognosis in these children. In addition to your usual temporal bone report, if you're looking for a cochlear implant candidate, make specific mention of mastoid aeration. You don't have active mastoid effusions. You cannot do cochlear implant surgery if the child has an active infection. Is the facial nerve dehiscent or does it have any aberrant position? Is the cochlea patent? Can you see 2 turns and a blob? The middle ear, is it well aerated or do you have a middle ear effusion? The inner ear canal, am I able to see the cochlear nerves? Is it patent? Are there any tumors in the location of the inner ear nerves? You have to identify these critical structures. In addition, check for cochlear calcification, because this could be a sequela of inflammatory conditions, most typically meningitis during the neonatal period. This is going to have very poor prognosis, and if you see significant intracochlear calcifications or concretions, cochlear implantation is relatively contraindicated. Remember, once you've had a cochlear implant, at the current time, MRI is contraindicated for any children who've had cochlear implantation. So you've got to do your complete and thorough CT and MRI cochlear workup before the cochlear implant has occurred. In the vestibular critical structure is the lamina cribrosa. It's a thin plate that separates the fundus, this is the fundus, this is the body, this is the inner acoustic pore, of the inner ear canal from the vestibule itself. If you have erosion of the fundus or if you have erosion of the other walls of the labyrinth, you have to think of an aggressive inflammatory condition, which is typically called a cholesteatoma. Erosion of the lamina cribrosa is a secondary sign of a cholesteatoma. No matter how severe your middle ear effusion is, it will not invade or violate the lamina cribrosa. The semicircular canals are named whether they are most posterior, most superior, or most lateral. You need to track them on various serial images because they're almost never, except for the lateral one, seen on one entire image. One of the landmarks is the facial nerve. It is always directly underlying the horizontal semicircular canal. So if you find your vestibule, you have the lateral or horizontal semicircular canal. Immediately under that, lying within the middle ear cleft, is going to be the facial nerve. At this location, the osseous canal of the facial nerve or the fallopian canal may be dehiscent. If it is, that's another variation of normal. Inflammation within the middle ear cleft can cause facial nerve pathology because it irritates the facial nerve. The lateral and the posterior semicircular canals, again, protrude laterally as well as posteriorly, and that's how they get their names. The most posterior semicircular canal is going to be the same diameter as the vestibular aqueduct. So you don't want to measure anything because there are lots of gender and age differences. If the vestibular aqueduct is bigger than the posterior semicircular canal. That is an enlarged vestibular aqueduct. If you don't have to strain yourself to find a vestibular aqueduct, that is an enlarged vestibular aqueduct. If you have an enlarged vestibular aqueduct, you are going to have some degree of deafness. And this has more to do with the embryology because it has to do with equilibration of fluids in the cochlear and vestibular systems. The facial nerve has several segments. Within the midbrain is the mesencephalic segment. Within the subarachnoid space is the cisternal segment, and then you have the canalicular phase. Within the fallopian canal is the labyrinthine segment, which is uniquely susceptible to inflammation, typically idiopathic. In the middle ear wall, you have the tympanic segment. Remember, if the middle ear wall is dehiscent, inflammation in the middle ear can irritate the facial nerve in this location. It then travels through the mastoid air cells. Inflammation or fracture of the mastoid air cells can disrupt the facial nerve in this location. Within the parotid gland, as we saw yesterday, the facial nerve travels and then diverges, and you've got many branches of the facial nerve in that location. So an excessive length of facial nerve, the longer the facial nerve, the more likely it is to get interrupted and undergo traumatic translation. The nerves can easily be seen from their output in the cistern, within the inner ear canal itself, and then you can track them along the subarachnoid spaces. There's the labyrinthine segment. There is a slight anteromedial hook in that location. This is where the geniculate ganglion lies because this is shaped like a knee. The geniculate ganglion is also prone to autoimmune or idiopathic inflammatory change. You can follow the facial nerve on serial images. By the time you get to the styloid process, the stylomastoid foramen is how the facial nerve descends before it leaves the temporal bone and extends externally into the parotid segment. Now, facial nerve disorders can be tracked to their location of disruption or traumatic translation by what else is being involved. If it's in the midbrain, facial nerve pathology invariably is going to be associated with sixth nerve pathology or palsy. If it's in the cistern, it's traveling with the auditory nerve, with the vestibulocochlear nerve, so you're going to have associated auditory or balance problems. If you have peripheral seventh nerve problems, it's typically going to be in the temporal bone. If these special functions, however, like salivation and taste are intact, then you know that the problem is after special branches have left, and that's going to be intraparotid in location. Facial nerve pathology is very, very non-specific. It's enlargement, abnormal signal, and or enhancement of any or all segments of the facial nerve. A neurinoma and a schwannoma will look exactly the same. Hemangiomas may or may not have spiculated calcific densities within them. Now we come into the ear itself. In the outer ear, almost all outer ear pathology is diagnosed by the ear clinic. Our only purpose is to diagnose extension and pre-surgical mapping of how extensive the malignant otitis externa is there chronic otitis media, is there cholesteatoma, and how far does it extend. For example, this is a middle ear effusion, and this is a cholesteatoma. They look for all purposes the same. There is non-focal uniform opacification of the mastoid air cells and or the middle ear cleft. However, over here, the lamina cribrosa is intact. The middle ear ossicles are not deformed, have not undergone any erosion, and there is no fistula formation. Here, everything's disrupted. The lesion is more expansile. The middle ear ossicles cannot be defined by definitive anatomy, and you may or may not get erosion of the bony structures around the vestibule and the labyrinth. So it's very important to look for indirect signs. The diagnosis of middle ear effusion or cholesteatoma is already made by tympanoscopy. You're not going to make it de novo in radiology. You're just looking at secondary effects. Looking at the anterior cerebellopontine sulcus, you're going to think of three kinds of problems: neoplasms, vascular or Petrous pyramidal problems. Because most of these issues have to do with the brain itself, the study of choice is something that can visualize the nerves themselves, which is going to be MRI. Because vascular pathology and neoplastic pathology can present similarly, it may be worth giving gadolinium DTPA to those patients who complain of a vascular ringing in the ears or tinnitus. A vestibular schwannoma is easily seen using short TR images. You can see them using hydrographic images. These are opposite sides of the same patient. Here you can see nerves entering the inner ear canal. Here this nerve is completely blocked. You don't see CSF, you don't see lymphatic fluid in that location because you've got a mass lesion over there. You can, of course, give contrast, and this is going to enhance. So contrast administration will not change your differential diagnosis in any way. But if you're not familiar with hydrographic imaging, which is like an MRCP, then this may help you increase your diagnostic confidence. And you may also be able to measure a little easier after giving contrast as compared to before contrast is infused. The shape and the volume of the vestibular tumor, the vestibular schwannoma, which is most typical, are critical in deciding whether or not surgery can be approached by one way or the other. Again, you don't have to give contrast because 7 out of 9 of tumors in the anterior cerebellopontine sulcus are going to be vestibular schwannomas. Nearly all of them enhance, but they have variable signal intensity. We've seen some that are hemorrhagic, some that are necrotic, some that erode neighboring structures, but they're still much more common than metastases, which is what we sometimes suspect them to be. If you see vestibular schwannomas, don't stop right there. Look at the rest of the brain. You could have other schwannomas associated, as well as an association with meningiomas. So again, this is the danger. If you don't get one full brain sequence, you're going to miss this and think of this as an isolated problem. Remember, if you've got bilateral vestibular schwannomas, you have type 2 neurofibromatosis. You could also have neurofibromas with meningiomas or other problems that can satisfy CDC criteria. So you may want to do post-gadolinium imaging, or just T2 star imaging with hydrographic technique is good enough. However, if you're suspecting vascular problems, it may be a good idea to give contrast and do high-resolution MR angiography. The 3D MRI, in my opinion, is good enough to determine exactly which nerve is involved. Again, not very challenging because audiometric and balance testing is also going to determine this preoperatively, and they're not going to rely on our diagnosis. A good way of remembering this is 7 up and coke down. This is the inner ear canal. Anteriorly, superiorly, you have the 7th cranial nerve, or the facial nerve. Anterior, inferiorly, you have the cochlear nerve. Because you've got 2 vestibular nerves, you have the superior and the inferior vestibular nerve, Bill's bar and the falciform crest, dividing these structures into 4 segments. Not only a vestibular schwannoma, but some other lesions in this location may present identically. It's quite unusual for a meningioma to enter the inner ear canal. Unusual, but not impossible, because you do have meningothelial rests in that location. This patient has additional dural plaques, meningioma on plaque, and a meningioma on the other side. Again, there's a larger chance statistically that this could represent a vestibular schwannoma. It didn't, it just happened to be a meningioma, but remember, vestibular schwannoma is the commonest thing in this location. Epidermoids look like CSF, but they are dirty CSF, so they don't completely suppress on flare sequences, and that's one way of telling them. They are benign lesions and may have nerves traveling through them. They're typically surgically excised if they are symptomatic. Don't forget glomus tumors. Glomus tumors are going to enhance when contrast is given. They are related to the cochlear promontory and present with a ringing in the ears. In the future, we're going to see additional criteria for cochlear implant candidacy, MR and ferromagnetically safe cochlear implants. Neurovascular anatomy is going to be identified better using spoiled gradient imaging. We don't really need to give contrast. Dynamic MRA with contrast phase shifts may be tracked as well. Right now, we're already looking at tracking central auditory pathways using a functional or bold blood oxygen level dependent MR imaging, and we're able to track what kind of sound is going to alert what part of the brain. Again, this may be of future importance in assessing for the viability of cochlear implantation. A few specific things when you're looking at the vestibular schwannoma. I like to add this because this is the commonest tumor in this location. Give us the volume of measurement. If you've got a 3D measurement tool, don't just give us the 3-dimensional size. Give us the volume of measurement because that's important for the surgeon. If you have a larger vestibular aqueduct than the posterior semicircular canal, specify that in the body of your report because that has poorer prognosis. You want to look at the fluid between the fundus of the inner ear and the vestibular schwannoma. If it's not simple fluid, if it's not hyperintense on long TR-weighted images, then you know beforehand that the prognosis is poor and you're not going to have recovery of complete hearing after surgery. Coronal images are always used fat suppressed because some focal fat may be remaindered within the apex of the petrous bone, and this can often be mistakenly thought to represent a tumor. Remember, you can have fatty rests as well as aerated segments at the apex. So again, in summary, the outer ear canal, you want to see that it's symmetric. Assess for patency because a lot of outer ear pathology may be congenital atretic plates associated with middle ear anomalies. It's embryologically linked. In the middle ear cleft, you want to look at the ossicles. The ossicles should be intact. Assess for aerations, especially of the middle ear cleft and the mastoid air cells. The inner ear structures, you want to look at the membranous and the vestibular labyrinth. You want to assess the nerves. The best way to assess the nerves is by using MRI. The outer ear canal, you're focusing on destructive changes and how far they extend into the middle ear, and focal mass lesions. In the middle ear cleft, do you have focal or diffuse soft tissue changes? Do you have erosive changes? Is ossicular integrity maintained? Very, very important. You're not going to be able to tell between a middle ear effusion and a cholesteatoma. You're going to assess the extent of the pathology. Inner ear structures, do you have any focal mass lesion or any focal enhancement? We're going to talk about the orbit and globe and the entire optic pathway in 30 minutes. Why just 30 minutes? Well, A, because that's all the time we've got, and more importantly, the eye clinic has these other tools, and they don't really need us. So if you get a request for an eye study, don't shoo it away, because eventually they're going to do all of eye imaging on their own. Ocular pathology is very simple because it typically occurs in children, and it is associated with an error of refraction. They almost never come to us for imaging without a pre-existing diagnosis. It is unusual and quite rare to make a de novo diagnosis of ocular pathology. There are some specific entities which we're going to cover. Orbital pathology is more common in adults. It's more commonly non-specific, typically associated with restricted or painful extraocular movements. In this area, we are evaluating things behind the corneoscleral limbus, which is not easily accessible to ocular sonography as well as direct ocular imaging. So we have some role in orbital pathology, but not a tremendous role in ocular pathology per se. Ocular pathology typically in children and typically investigated using CT. Orbital pathology, typically MRI, because not only do you want to evaluate the orbit, you want to evaluate the orbital apex and the remainder of the retroorbital visual pathway, which includes the entire brain. Painful or restricted extraocular muscles, you want to use MRI. Childhood ocular pathology, you want to use CT. It's as simple as that. When do you use CT? Well, if it's not safe to do MRI, it's a good idea to do CT. In the traumatic setting, in the urgent ocular setting, you want to do CT. Pediatric pathology, more likely ocular. Pre-surgically for craniofacial reconstruction, when you have to get dural flaps and titanium molds made for reconstructive surgery in syndromic kids, you want to do optic CT. If you've got orbital pathology, but it is for some reason or other unsafe to acquire an MRI, you want to do CT as well. Typically, you get 3 millimeter sections from the sella to the maxillary sinuses. You have a larger field of view because you do not want to exclude neighboring pathology that may extend into the orbit itself. However, if you're suspecting trauma, if you know there's trauma, or if you're suspecting underlying retained foreign bodies, you want to get thinner images. You may use contrast infusion, iodinated contrast, but it's almost never going to change anything unless you're suspecting some kind of vascular pathology. So contrast is not universally used, but it may help strengthen your diagnostic differential. It's not necessary to acquire images in both the axial and the coronal planes, because if you use 1.5 millimeter thick sections, you can reformat them in any plane you wish, as well as 3D imaging for intrasurgical navigation using your InstaTrack or other navigational systems in the operating theater. Optic MRI indications, if you're suspecting pathology outside the globe but within the orbit, typically some kind of restriction or painful extraocular movement. Neuro-optic syndromes, these are typically associated with other congenital problems, maybe in kids or in adults. Suspicion of epidural violation. This is something that is going to involve a neurosurgeon, a very aggressive infection or neoplasm that may have spread outside of the osseous skeleton of the orbit, and chronically restricted movements of extraocular muscles that could be tracked because of neurogenic problems from nerves that supply the extraocular muscles. So if you're concerned about the orbit and little more than the orbit itself, you want to consider getting an MRI. There are structures around the orbit. Those are the optic nerves in the coronal plane. You've got the extraocular muscles, the vessels in that location. There's the carotid vessels in the cavernous sinus. All this can be completely evaluated using MRI. You can get only indirect evidence of pathology of these structures using CT, and therefore you must think of MRI because of neighboring structures. You could have aneurysms, or you could have metastases that affect, either by pressure or direct infiltration of the extraocular nerves that supply neurogenic signals that cause restricted motion. So you want to look at the complete optic pathway using MRI. For optic MRI, surface coils are used. It's very important to know which orbit has been involved, because you can target sagittal imaging to a particular orbit. Remember, you want to tilt the surface coils in such a fashion that it is perpendicular to the plane of the optic nerve. And if you don't get the exact plane, you can tilt your image acquisition a little bit more. But it's very important to have dedicated surface imaging. Just like in the temporal bone, we get one singular sequence through the entire brain, because you want to look at the entire brain and central optic pathway involvement. Contrast may or may not be given. If you should choose to give contrast, remember to use some form of fat suppression. I prefer using frequency selective fat suppression, but whatever works best in your magnet. Whatever planes you use before contrast, use identical planes, window and level your images at those identical settings, so you are not fooled into overreading the amount of contrast enhancement. Again, contrast enhancement not a must. Once you have your axial images through the brain, it's very easy to identify the globes. You're getting a smaller field of view. The vitreous humor is the wettest structure in the human body. So it's going to be super bright. It's hyper intense on long TR images. The ocular lens is the driest structure in the human body. So it's going to be a signal void. Once you determine what's going on, any signal abnormality other than bright white on a long TR sequence is indicative of pathology within the vitreous humor. That's very, very critical. You can see the optic nerves, you can see the optic nerve sheath complex, and the CSF surrounding the optic nerve. This is key because this determines the angulation of your plane of acquisition. Further images through the orbits are going to be either parallel or perpendicular to the optic nerve itself. This way you can visualize the entire optic nerve, the CSF surrounding it, and the optic nerve sheath complex. You don't really have to give contrast, because if you have any pathology involving the optic nerve, it is going to efface and impinge upon the subarachnoid space in that location. Pathology in the structure, in the fat around the optic nerve, is going to compress upon this externally, acting upon the optic nerve to cause compressive neuropathy. So you can do this, and you can assess the entire course of the optic nerve using oblique imaging once you have the plane of imaging parallel and perpendicular to the optic nerve itself. A question we're often asked is, what about foreign bodies in the orbit? Is it safe to do MRI if you have somebody who's been a metal worker or who has indicated that there is a possibility of having a foreign body in his or her eye? The answer is pretty simple. If the foreign body is outside of the globe and it's embedded within the fat, the torque exerted by a standard clinical magnet, which is 1.5 Tesla or less, is insufficient to cause any significant deflection of the fat and therefore of the metal embedded in the fat. If the metal's been there for a while, it's probably undergone some kind of fibrotic reaction and is anchored even firmer. However, if you have a foreign body that is retained within the globe itself, it's free to move. These people are going to have some kind of impaired vision. So the very fact that the person actually came to your registration and filled in his MR screening form means it's safe enough to go and scan him. But of course, most of us are extremely paranoid, and we keep getting these rule out radiopaque foreign body in orbit limited views. Some of us even do CT to look for these retained radiopaque foreign bodies. We haven't done that for over 7 years, and it's been working for us. Again, there's not enough of a library of evidence to support this one way or the other. You've got to come up with your own departmental policy, which is whatever you're familiar and confident with. In my opinion, it's a waste of time studying these anymore. If you've got an intraocular foreign body, you need to be in the ER or the OR and not the MR. Anything else, you're safe to come on down and get scanned. The optic pathway is divided into the anterior compartment, typically easily assessed by clinical inspection. We're horrible at this because we often miss pathology. We're not looking at things in front or anterior to the corneoscleral limbus. The orbital septum is an artificial division. Things in front of it are easily seen on direct inspection. Things behind it are in the posterior compartment and not clearly visualized, and that's why we do CT or MR in these patients. The extraconal fat is very, very invaluable in further imaging of the orbit because infiltration or pathology of the extraconal fat is always pathological. You do have to see normal fat that suppresses normally and follows the signal of fat, be it on CT, MRI, or ocular sonography. Abnormal fat in this location signals something is going on. For example, now here's a BB marker, so we know that even the technologist can see that there is an angular dermoid in that location. Why are we doing a CT? We want to see whether this dermoid extends posteriorly behind the septum into the retroseptal compartment. Does this have any adhesions with the underlying lateral wall of the orbit? Are there any other associated anomalies to do with the globe or the supporting structures? This is melanoma of the eyelid, very clearly seen enhancing structure involving the eyelid. Because you have the uveal choroid in a nearby local region, you want to see if there are deposits of melanoma elsewhere in the ipsilateral or contralateral globe or extraocular orbit. So we're not looking at anterior compartmental structures because we're not going to add any information, but we're looking at extent of disease, and this is very important in staging of tumors and in pre-surgical planning. Fibrous dysplasia typically involves the vertical or ascending plate of the frontal bone. It's a benign lesion. It does not undergo malignant transformation with any significant frequency. It does present in a very classical formation. We don't see cortical breakthrough. It has matrix within it. Chronically entrapped rectus muscles. If you've had fractures of the papyraceous lamina in the past, you see displacement of the rectus muscle, and this can be a cause of restricted or painful extraocular movement. If you have ocular pathology, the first thing you want to assess is the size of the globe. Is it too big, is it too small, or is it normal? The way you can say either of these is by comparing it with the other globe. There are no normal standards. Sometimes both globes may be pathologically enlarged, and that can be quite challenging. Bilaterally deformed globes are obviously easier to diagnose compared with bilaterally small, shrunken globes or brighter globes. Then you want to look at globe calcification or abnormal signal or attenuation within the vitreous. Remember, the brighter vitreous is going to be the more abnormal vitreous on CT. The darker vitreous is the more abnormal vitreous on MR. And that's going to give you an idea of which globe is abnormal. Calcification or masses within the globe are obviously always abnormal. Non-specific, but a very sensitive sign of abnormality within the globe itself. Ocular pathology is typically described as either associated with leukochorea, which is a pinkish white cat's eye reflex, associated with a congenital brain malformation, or associated with some form of detachment. There's a laundry list of leukochorea in your syllabus, and we're not going to go through all of that right now because you just want to focus on what's really important. Why do you get leukochorea? The incident beam of light falls upon the retina, which is highly vascular, so you've got reddish reflections of incident white light which falls back upon your eye. Anything in the path of the incident or reflected beam before it is reflected back upon the observer is going to cause an interruption of that red signal or red light, and that's going to cause a pinkish yellowish reflex, and that's what is manifest as leukochorea. The larger the obstruction to the reflected light, the clearer the leukochorea, the clearer the obvious fact that there is indeed some kind of malignancy. It is the commonest presenting sign of retinoblastoma in children, but it can be caused by anything that blocks the reflection of light. At any age, intraretinal detachment, because now the retina is not as well supplied by blood, so you have vitreous exudates and retinal fibrosis, is going to stop reflection of reddish light. The light's going to be white or pinkish in this location. Choroidal or retinal hemangiomas are going to scatter light further, and you're not going to get a normal red eye reflex. In the elderly, senile macular degeneration is the commonest cause of legal blindness as well as of a cat's eye reflex. So typically in kids, if you have leukochorea, always think of a retinoblastoma. Small kid, typically under the age of 5 or 8 years of age, and presenting with calcification in the globe, and or leukochorea has retinoblastoma unless proven otherwise. In adults, you have to think of malignant uveal melanomas. Radiologically, and using ocular sonography, they present identically. Uveal metastases would look exactly like that. Impossible to differentiate between these two unless you have histological proof. In the elderly, you have senile macular degeneration, which is incidental and common. Retinoblastoma is known as the unlucky tumor because the mean age at presentation is 13 months, and it is related with a locus on chromosome 13. If there is extraocular spread, if it has spread outside of the globe, mortality is very, very high. Even after removal of the globe and total orbital irradiation, because these kids have a genetic predisposition to cancer, they're more at risk for other tumors like renal cell carcinoma outside the radiation port, osteosarcoma within or outside the radiation port. Typically presents with calcification, which may either be spiculated or small flecks or speckles, or could be amorphous. The tumor itself is very, very small. The tumor is not visualized directly. The protein that is responsible for this tumor causes calcific deposits that are minor. These cause neovascularity in the local region and then retinal detachments, as well as vitreous hemorrhages that have fibrosis and dystrophic calcification. So the calcification is actually a signal as to what's going on in the vitreous as well as in the retina. It is not any indication of the size of the tumor itself. The tumor may be very, very small. This is a reaction to the tumor. The absence of calcification, however, does not rule out a tumor, because you do not see calcification in 10% of children, as there has not yet been time to cause this cascade of reactions that causes calcification. And that is why we promote MR, because on MR you can see the tumor even before calcification has occurred. This is a child with non-calcified globes, but with an extensive tumor. The tumor is very small at histology, but there is reactive fibrosis and retinal detachment associated with the tumor. If you can look at the signal of the vitreous, this is abnormal vitreous, this is normal vitreous. After contrast infusion, you can see that the mass enhances because of neovascularity that is related to the tumor, but not the tumor itself. If you look very critically, there is contralateral tumor as well. And this is very key because bilateral retinoblastoma clearly has more of an association with poor prognosis, because the other option is bilateral enucleation. In kids with smaller globes, you must think of torch infections, especially cytomegalovirus inclusion disease, as well as defects in fusion of the uveoscleral tract. If the child is older, you must think of astrocytomas. Astrocytomas are probably the only thing which look quite similar to the retinoblastoma at fundoscopic examination. However, because the treatment is the same, you're fine if you look at a normal-sized globe in some kid under the age of 3 and think of a retinoblastoma. You're not doing any disservice to the kid. Malignant uveal melanomas look very, very similar. Remember, the uveal choroid is the most vascular structure in the human body. But because it has a rete mirabile, it does not have the incidence of metastases as we see within other parts of the brain. However, because we have melanotic pigmentation and high vascular flow, this is a classic location for melanoma. If you have uveal metastases, they're typically bilateral and 33%. Remember, orbital or ocular metastases, very poor prognosis. Typical survival is between 3 and 6 months. So be very careful before you diagnose metastases in the orbit. Choroidal hemangiomas present identically to uveal melanomas in the older age group, but are invariably associated with syndromes like the Sturge-Weber or the von Hippel-Lindau syndrome. In kids, to review, a normal-sized globe with a calcified mass, think of a retinoblastoma. Yes, it could be an astrocytomas, but we see retinoblastomas with alarming volume as compared to the astrocytomas. A non-calcified mass, either think of a parasitic problem like toxocariasis or Coats disease in preteen boys only. If the globe is small, if it's unilateral, it's more likely to be persistent hyperplasia of the primary vitreous, which is a congenital condition. If it's bilateral, it's more likely to be retinopathy of prematurity. I say more likely because we do see these reversing all the time. Because of controlled oxygen delivery systems, it's been quite a while since we've actually seen retinopathy of prematurity. Congenital disorders, we're not diagnosing them per se using CT or MRI. We're looking at associations. Do you have a very tiny globe because of torch infections? Do you have no globe because of some kind of anterior premaxillary craniofacial dystrophic syndrome? Do you have macrophthalmia, typically associated with the phacomatoses, syndromic associations? A coloboma, failure of fusion of the uveoscleral tract, almost invariably indicates failure of fusion along the midline. Callosal agenesis is often associated. So again, we know what's going on. There is a syndromic association. We're looking for other things to help fit the picture and fit CDC criteria. For example, plexiform neurofibromata in the ipsilateral face associated with a deformed orbit. Ipsilateral choroidal hemangiomas within the ocular choroid and the glomus of the choroid plexus, a diagnostic sign of Sturge-Weber syndrome. You're picking this up before there's going to be any gyral calcification or dystrophic volume loss, dilated medullary veins, a smaller cerebral hemisphere because of shunting of blood flow. You're not looking at the primary pathology, you're looking at associations, and that's why you have one sequence which looks at the entire brain. Detachment is one of those tricky things because it's catastrophic, it's dramatic, it's a surgical emergency. It's very unusual that any of these would present to radiology unless it's incidentally visualized when you're looking for something else. The classic example is the intraretinal detachment. This is the one we most often see in radiology. It's intraretinal because it is not really detachment, it is retinoschisis. It is dissection between the sensory and the pigment epithelial layers of the retina. Because of this, the retina is displaced from its normal location. It starts at the edges of the optic disc and stops at the ora serrata. Remember, this is a surgical emergency. You've got to do cryopexy if it does not involve the macula and if it's very small. Other choices of treatment include scleral buckling as well as placement of air or silica oil or gel to seal off the retina. The longer you wait, the dissection is going to be more progressive, catastrophic in onset. This is easily diagnosed by lifting up of the retina, stopping at the ora serrata, looks exactly like this, so they almost never come to radiology for any imaging. Posterior hyaloid and suprachoroidal detachments typically associated with what is imminently a non-viable globe or globe rupture. The orbit itself acts like a glove around the globe. Graves' disease, the commonest orbital pathology in adults. Lymphoproliferative disorder may represent lymphoma or lymphoma-like disorders. Orbital pseudotumor, which is very, very commonly seen in adults, but we're seeing smaller fractions of children being involved by orbital pseudotumor. Vascular lesions, all of them behave in a similar fashion. They can be diagnosed only at biopsy, and each of them has different treatment options. Epithelial neoplasms, at which we're completely useless at differentiating benign from malignant ones because they all look radiologically similar. MR and CT very sensitive but not specific in diagnosing the types of vascular or epithelial lesions. Graves' disease is typically diagnosed clinically, and as you've seen, you know using nuclear medicine technology how this can be diagnosed as well as treated. Early signs of Graves' disease may be manifest with thyroid orbitopathy even before there is change in serum hormonal levels. If you have bilateral exophthalmos, almost all of them have Graves' disease serologically or are going to develop it in less than a year. Dysthyroid orbitopathy not only affects the muscles by enlarging one or more muscles unilaterally or bilaterally over a period of time, the fat itself is going to be dystrophic. There are going to be autoimmune deposits in the fat, which is going to cause proptosis or anterior displacement of the posterior sclera. This is what is causing the proptosis. This fat is not going to suppress with normal fat suppression techniques. The enlarged extraocular muscles, again, sensitive but not a very specific sign of dysthyroid orbitopathy. Remember, your hormonal levels may be normal at this time. So there is a laundry list of a differential. For example, lymphoma. Lymphoma may present as an apical process in the orbit, which is plastered against the osseous orbit but does not displace or destroy anything. Or it may involve a muscle itself thickening one or more muscles unilaterally or bilaterally. Lytic processes like metastatic neuroblastomas may or may not involve the walls of the orbit, but if you have destruction and epidural enhancement or epidural violation, you've got to think of some kind of aggressive tumor, especially in children. The commonest ones are neuroblastomas, Ewing tumors, and rhabdomyosarcomas. Orbital tumor is typically seen in adults when it is typically unilateral. The few cases you see in children are almost always going to be bilateral. Orbital pseudotumor is a diagnosis of exclusion, and you can only diagnose it using imaging by its prompt response to steroids and a vanishing of the dirty fat. The fat is always infiltrated when you see orbital pseudotumor. It's very non-specific because it's any age group. It could be unilateral or bilateral, and it can affect any compartment of the orbit. However, whenever you see orbital pseudotumor, the fat is always infiltrated. So do not even think of orbital pseudotumor if you don't have two things: a prompt response to steroids, a painful orbit, and of course, reticulation of the fat. If the fat is reticulated or does not suppress using standard fat suppression sequences, please do not think of orbital pseudotumor. All this said and done, do not forget the optic nerve, which is actually what connects the globe with the rest of the visual pathway. There are no normal measurements to look at the optic nerve. If it appears wide and thickened or tortuous, then you've got to think of optic nerve swelling, typically seen in optic nerve gliomas, more commonly seen in children. It's bilateral in girls. They may be associated syndromically with neurofibromatosis. Optic neuropathy often precedes multiple sclerosis, but it is more the exception than the rule. If you have optic neuropathy, the chance that you have multiple sclerosis or ADEM, acute disseminating encephalomyelitis, is actually quite rare. Only 10% of patients with optic neuropathy are ever going to go ahead and develop ADEM or MS-like lesions. And optic neuropathy is diagnosed fundoscopically. So why are we imaging the brain? Because there is a risk of progression to MS, and you want to document at that moment in time. Remember, multiple sclerosis and MS-like lesions demonstrate lesions in the central nervous system separated in space and time. At the time of the attack of optic neuropathy, you want to document that the brain was intact. Therefore, if you have one other event in space or time, you can satisfy the criteria for diagnosing multiple sclerosis. There are many phases of optic neuropathy in multiple sclerosis and MS-like lesions. In the early phase, the optic nerve is normal. During the capillary phase, there is leakage, and therefore there is slight enhancement. During the edema phase, there is thickening and prominence of the optic nerve with heterogeneous enhancement. This may be completely missed if you're using thick sections. During the subacute and chronic phase, the optic nerve reverts back to normal volume, but you may or may not have optic nerve hypoplasia at that time because you have neuronal death. So again, optic neuropathy, very, very challenging to diagnose using imaging, very easy to diagnose by direct fundoscopic examination. Other things that can look like orbital pseudotumor, sarcoidosis. Remember, most sarcoidosis present with uveoscleral problems before they have thoracic pathology or chronic fatigue. Typically involves any segment of the orbit but favors the lacrimal glands. We'll have symmetric enlargement of the lacrimal glands, but the uveoscleral tract is typically identified as being involved as well, which is during direct inspection of the globe. Orbital cellulitis in kids from paranasal sinuses, typically ethmoid sinusitis, in adults from sepsis or facial cellulitis. Again, cellulitis may extend around the orbit and globe, so it could be para or preorbital, but once it enters the retroocular segment, it's very important to treat this aggressively. Whenever you see infection or trauma involving the globe, one thing you must include in your consultation is the integrity of the sclera. That's very important. Two things we insist are indicating that there is no retained radiopaque foreign body, because that itself acts as a nidus for infection. The second thing is the integrity of the sclera bilaterally. If there is violation of the sclera posteriorly, this vitreous humor is going to leak into the posterior fat. This is foreign protein and recognized by the body as such, which then mounts an autoimmune response, and therefore the vitreous humor on the contralateral globe is going to undergo what is called sympathetic endophthalmitis, and therefore you're going to be blind in both eyes. So if you have violation of the posterior sclera, you typically remove that globe in order to preserve monoocular vision in the contralateral globe. So always, trauma cases and infectious or inflammatory cases, mention immediately that there is no retained radiopaque foreign body and that the posterior sclera is intact. Once you have a drainable fluid collection, an orbital subperiosteal abscess, it's a little too late to undergo IV parenteral antibiotic therapy. Surgical cleaning of this is required. Of course, you have to treat the sinus inflammatory disease as well, but right now you've got to drain the drainable fluid collection. Trauma, again, can be very dramatic. Remember, the sclera has amazing sealing potential. This is what happens when a child runs with a pencil. The pencil stops and the child keeps going. You've got hemorrhage within the vitreous humor, but the posterior sclera is intact. The anterior sclera seals off immediately because it's leathery and tough, and therefore it keeps the blood within there. It maintains the tone of the globe. If the tone of the globe is lost, if it does not look like an oblate spheroid anymore, if it's a shriveled up raisin instead of a grape, remember uvea means grape, then you've got to deal with that globe. Either fix it with a pars plana vitrectomy, clear everything off with saline irrigations and replace the vitreous, or remove the globe itself. This is a ruptured globe. The posterior sclera is not intact. Vitreous is leaking out. This is after direct trauma. The globe now needs to come out before you have sympathetic endophthalmitis of the opposite side and you lose binocular vision. Other aggressive infections are typically seen in those who are severely and uncontrolled diabetic, otherwise immunocompromised or debilitated patients, these can spread to the intracranial structures with epidural violation. However, they have non-specific appearances and look like garden variety bacterial sinus inflammatory changes. Vascular lesions, there is a large list of them. The capillary hemangiomas, typically seen in children, resolve on their own by the time the child starts going to school. The older school of thought was to treat these with sclerotherapy. We now let age take its own course. Cavernous hemangiomas may bleed into themselves, and therefore they're better taken out as soon as they are diagnosed. Venolymphatic malformations, formerly known as cystic hygromas, can be very aggressive and cause proptosis because they are large venous vascular channels. Venous varices bleed into themselves and are aggravated by fluctuations in venous blood pressure. Carotid to cavernous fistulas may be idiopathic or post-traumatic. They are typically associated with significant enlargement of the superior ophthalmic vein, which is a congestive phenomenon. This is a capillary hemangioma, more of an anterior structure, so it's clinically visualized anteriorly by direct inspection, fairly homogeneous enhancement. This is a cavernous hemangioma. These channels are slightly larger when compared to the capillary ones, and therefore they do not seal off and resolve on their own. They are going to need to be removed because they have a tendency to bleed outside of their pseudocapsule and therefore have catastrophic intraorbital hemorrhage. They do enhance fairly uniformly in nature. The venolymphatic malformations are channels of remnants of the jugular ductal venous system. These undergo tremendous pressure changes and can cause mass effect on the orbit. The venous varix behaves similarly but bleeds into itself, typically presents like a complicated bloody bone cyst with multiple fluid-fluid interfaces because of layers of repetitive blood and blood products. They have to be removed as well. All you can tell when you see an epithelial neoplasm, just like the vascular neoplasms, is whether they are well circumscribed or infiltrative. Do they involve the anterior compartment or the posterior compartment? It is really quite impossible to give any more information than this. If you look at the list of the well-circumscribed neoplasms and the poorly circumscribed or infiltrative neoplasms, there is almost a 33% overlap. So don't try and give a histological diagnosis, just define it anatomically. Also use a little bit of common sense. If you're a kid, you're more likely to have childhood tumors like embryonal rhabdomyosarcomas. If you're an adult, you're more likely to have melanoma or lymphoma. Orbital neoplasms are easily seen either on CT or MRI. The addition of contrast does not really change your differential further. All you want is information regarding the location. Is it more anterior or more posterior? Is it well circumscribed or is it infiltrative? In children, the commonest type of tumor in the orbit is going to be a primary rhabdomyosarcoma. But you can have orbital metastases, typically from a neuroblastoma. This has periosteal newborn formation, very similar to an osteosarcoma. In adults, metastases may be most commonly seen from the breast. Again, if you have metastases in the orbit, you have very, very grave prognosis. So be very careful before you bring this up into the diagnosis. When this is in your differential diagnosis, you can do histological examination to confirm whether or not that is indeed the case. To summarize, ocular pathology, typically leukocoria. In children, retinoblastoma. In adults, uveal melanoma. Also think of metastases, cannot tell one from the other. Congenital disorders, you're not looking at the disorder itself, you're looking at associations, extraocular associations within the brain because of congenital brain malformations. Detachments, very rarely diagnosed but maybe incidentally visualized, typically the retinal detachment, which is schisis within the retina because of detachment of one epithelial layer from another. Graves' disease, proptosis, maybe unilateral or bilateral. The commonest cause of orbital pathology has to do with Graves' disease. Lymphoproliferative disorder, lymphoma or lymphoma-like diseases can involve any segment of the orbit, typically going to be unilateral, typically not going to destroy any of the osseous lining of the orbit. Orbital pseudotumor, a diagnosis of exclusion. The fat is infiltrated. This is painful. It responds to steroids. Can involve any part of the orbit. Vascular lesions. Anything in the anterior compartment is more likely to resolve on its own. Anything in the posterior compartment has a predilection to rupture into itself or rupture into the retroscleral orbit and cause mass effect and catastrophic hemorrhage, and hence has to be removed. You cannot always make a pre-surgical diagnosis. Epithelial neoplasms, impossible to pre-surgically histologically stratify. All you're telling us is whether it's well circumscribed or whether it's infiltrative.
We talk about suprahyoid neck today. We start with the oral cavity. Obviously, this uppermost portion of the aerodigestive tract. Content, the two-thirds of the anterior two-thirds of tongue, buccal mucosa, we'll talk about. These are more important areas. And pathology of the oral cavity and floor of the mouth. Both CT and MR are excellent modalities for evaluation of soft tissues of the neck. CT by far is more commonly used because of its ease of use and is more comfortable for patients, and you can repeat it much more quickly, scheduling, all different factors. But overall, if there was a choice, MR to me is better obviously than CT, but it is much more prone to motion artifacts and scheduling and all that. So it's, in most centers, CT is the modality of choice at this time. We talk about benign lesions of the oral cavity, thyroglossal duct anomalies, hemangioma, rhabdomyosarcoma, and few other pathologies. Thyroglossal duct anomalies, they make 70% of all congenital abnormalities of the neck, and this divides into two categories of thyroglossal duct cysts and ectopic thyroid. Thyroglossal duct cyst is a cyst along the track of migration of thyroid gland from foramen cecum at base of tongue to the thyroid bed. The cyst could happen anywhere along this course, but 65% of them they happen in the lower portion of the thyroglossal duct in the infrahyoid region. In that case, they're usually off midline to one side. About 2 to 15% of them, they happen at the level of the hyoid, and about 25% of them, they happen above the hyoid. They're well-demarcated cysts, fluid signal intensity on MR and fluid density on CT. They show no enhancement, and it's important to know if they are below the floor of the mouth and extend into the in the submental region, they can be surgically resected from the outside. Otherwise, they have to be resected from above. Thyroglossal duct cysts are usually incidental finding. This is a small thyroglossal duct cyst, infrahyoid at the on T2 weighted images, very bright, well demarcated, and very poorly visualized here on T1 weighted images, but fat sad, bright on T2 again. Of other pathology of thyroglossal duct area is the lack of migration of thyroid gland along the course of thyroglossal duct into the thyroid bed. This is a disease that is more common in female than males, and approximately 75 to 80% of individuals that have lingual tonsil, which is the most common form of poor migration of the thyroid gland, they have no other functioning thyroid. So these can be resected if they cause symptoms, and they can be transplanted someplace else in the body, usually under the skin in the abdomen, because they won't have any other functioning tissue. They are usually asymptomatic, but if they become symptomatic, symptoms include difficulty swallowing, bleeding, and difficulty with the speech. We talk about ranulas. These are mucus retention cysts of minor salivary glands or the sublingual glands. It's usually caused by a trauma in the oral cavity, usually surgery. The outlet of the glands occludes and the cysts form. As long as cyst is intact, it does have an epithelial lining in it. As long as it's intact, it's called ranula. When it ruptures, which often they do, they dissect along the fascial planes, and most commonly they end up in the submandibular region. These are called lunging ranulas. The treatment for these is marsupialization. They open the wall of the cyst and they open into the oral cavity so the fluid would not accumulate. Of malignant lesions of the oral cavity, these two make 100%, nearly 100% of all the lesions of the malignant lesions of the oral cavity. 90% squamous cell carcinoma, 5% non-Hodgkin's lymphoma. It's very important to know that you cannot differentiate between the two by any of modalities of CT or MR. Carcinomas of the oral cavity are slightly less malignant than carcinomas of nasopharynx, and that's because the mucosa of the oral cavity is arising from the epithelium. The epithelium arises from the ectodermal origin, while in the nasopharynx it arises from the endodermal origin. So the carcinomas are less differentiated in the nasopharynx. These are disease of middle-aged individuals with long history of alcohol and tobacco abuse, and they're more common in the lower portion of the oral cavity, and that's supposedly because of longer exposure of the tissues along the lower portion of the oral cavity to nicotine and alcohol. They produce a mass, they deform the anatomy of the oral cavity, and that's how we see them. They may show some enhancement, but many of them may show absolutely no enhancement. This is a mass in the base of tongue with involvement of the musculature of the floor of the mouth and extending inferiorly into preepiglottic space. The single most important reason for doing this study is not so much for making the diagnosis of cancer. Often these patients already have the diagnosis of cancer by physical exam, but it is to evaluate for the nodes and measure the nodes and localize them so they can stage the cancer. Many of these tumors, by the time of diagnosis, they already have metastatic nodes. This is another case, very large necrotic mass in the tongue. You wonder how these patients can actually go this long without being diagnosed or treated. Again, produces distortion of the anatomy of the floor of the mouth, very well visualized, tongue with necrosis. Actually, it's the same case on the MRI. I don't know, CT shows many of these lesions very nicely. This one again demonstrates on T2 weighted images as a bright central necrosis, very poorly visualized along the floor of the mouth, and obviously there's very minimal enhancement associated with it. This is another case, involves the base of tongue, very large loculated mass with big necrotic nodes, squamous cell carcinoma of oral cavity or lymphoma. You cannot tell. This one, biopsy-proven lymphoma. Of lesions of the nasopharynx, we talk about superficial space. That's the space that is exposed to the air. Deep spaces, parapharyngeal space, and masticator space and carotid space back here. We'll discuss some pathologies of these spaces. First, about the nasopharynx. It both has squamous and columnar epithelium. And lymphatic tissues, obviously, a group of musculature, torus tuberous, and fossa of Rosenmuller. Very important because it's the most common site of squamous cell carcinoma of nasopharynx. We talk about squamous cell carcinoma of nasopharynx. These are, again, more malignant than oral cavity carcinomas. They happen 1 in 100,000 in white population and 20 times higher in southern provinces of China. Most, again, very similar to the oral cavity carcinomas, is a disease of the middle-aged individual, again with alcohol and tobacco abuse. And most common site of involvement is lateral pharyngeal recess or fossa of Rosenmuller. These tumors, by the time of diagnosis, they have metastatic nodes, and about 50% of them, they have bilateral nodes. This fossa of Rosenmuller, if you follow the posterior wall of nasopharynx laterally, it would end into a small impasse. It's a folding of the mucosa that travels along the superior and posterior aspect of the nasopharynx. It's immediately posterior to the eustachian tube, So tumors in this location can apply mass effect on the eustachian tube, and patients may present with middle ear infection in elderly. Sometimes these patients have seen physicians several times for ear infection while they are developing a larger and larger tumor in the nasopharynx. Fossa of Rosemuller would be immediately anterior to longus colli muscle. If you follow this one, on this side, obviously you can see a very large enhancing tumor right here with associated adenopathy on the opposite side in the carotid space, actually. Large necrotic node. Differential diagnosis, squamous cell carcinoma in the fossa of Rosemuller or lymphoma, you cannot tell. This is another patient with a much larger tumor with invasion into the skull base and erosion of the skull. This is the most common route of a squamous cell carcinoma of nasopharynx to extend into the central nervous system, direct extension. And this one obviously shows a significant amount of tumor extending to the tonsillar region and large necrotic nodes. Again, location of the nodes, the number of them, and distribution of them helps significantly in staging the disease. Of other group of pathologies in the nasopharynx, lymphomas. You cannot differentiate one from the other based on CT or MR. As again, it's usually a non-Hodgkin type form, very similar to the oral cavity. It can involve any portion of the Wall-Ayers ring, and it's rarely only in the nasopharynx. There would be other areas of body that would have lymphoma. Again, if you were looking at this case without the history, first diagnosis would be squamous cell carcinoma of nasopharynx with significant compromise of the nasopharynx, and obviously with some adenopathy, necrotic node in the neck. This is another case involving the base of tongue and tonsillar bed, enhancement, necrotic node, differential diagnosis, squamous cell carcinoma, or non-Hodgkin lymphomas. Rhabdomyosarcoma, another disease of the nasopharynx. This is a disease of the younger individuals. There are two peaks in life for incidence of these tumors between ages of 2 and 5, and then between ages of 15 and 19. These are very slow-growing tumors. The patients, again, they can present repetitively as a kid with congestion, sinus disease, difficulty breathing, snoring, and all that if they don't get a good physical examination, these tumors can be missed. They can invade the skull base, as you see in this patient, extends into the middle cranial fossa, entire maxillary sinus is involved, middle ear cavity is getting involved, and also extends superiorly into the orbit and cavernous sinus and middle cranial fossa. These tumors can be treated with surgery, and about 15 to 30% of them may have actually metastatic nodes.